Greetings to our next generation of compassionate and skilled nurses. Welcome to another high-yield NCLEX session. Today's video is all about the pharmacology of analgesics, a must-know topic packed with critical concepts on opioids, non-steroidal anti-inflammatory drugs, patient-controlled analgesia, and pediatric safety. We bring you new NCLEX-focused videos daily, covering the exact topics and question styles you need to pass the exam. In this session, we'll go through 23 important NCLEX-style questions with clear explanations to help you understand and apply what matters most. These are high-yield, exam-relevant scenarios you cannot afford to miss. So stay with us, follow for daily content, and let's get started. Question number 1, and it is one every nurse must be able to navigate confidently during the NCLEX and real-life clinical practice. A client with metastatic cancer reports a sudden and intense onset of severe pain rated 10 out of 10 on the pain scale. The nurse assesses the client and notes stable vital signs and alert mental status. The healthcare provider prescribes an immediate intervention for breakthrough pain. Which of the following medications should the nurse anticipate administering to provide the most rapid and effective relief? Now, pause for a moment and carefully consider each of these possible interventions. Option A, fentanyl transdermal patch. Option B, nortriptyline. Option C, celecoxib. Option D, hydromorphone intravenous. So what is the best choice for immediate and powerful relief in a breakthrough pain crisis? The correct answer is Option D, hydromorphone intravenous. Let's walk through this together. Hydromorphone is a potent opioid analgesic, and when administered intravenously, it begins acting within minutes. This makes it the go-to drug for acute severe pain, particularly in clients with advanced or metastatic cancer. Because of its high potency, it is vital that the nurse monitors the client's level of consciousness, respiratory rate, and blood pressure to prevent serious opioid-related complications like sedation or respiratory depression. Now let's explore why the other options are not suitable in this urgent situation. Option A, fentanyl transdermal patch may be a strong opioid, but it is formulated for chronic pain control, not acute relief. Its effects are gradual, taking up to 24 hours to reach peak effectiveness. Option B, nortriptyline is a tricyclic antidepressant that is often prescribed for chronic neuropathic pain, but it requires several days to weeks to become effective and does nothing for sudden, severe pain. Option C, celecoxib is a non-steroidal anti-inflammatory drug used for inflammatory pain conditions such as arthritis, but it lacks the strength and speed needed for breakthrough cancer pain. So remember, in cases of intense, sudden pain in cancer clients, your first-line action must be an intravenous opioid, and hydromorphone intravenous fits that need perfectly. Let's keep the momentum going with a teachable moment that highlights safe nursing practice around patient-controlled analgesia. Get ready, here comes your next challenge. Here comes question number 2. Following a professional development session on patient-controlled analgesia, the nurse reflects on safe practice principles for postoperative pain management. Which of the following statements by the nurse demonstrates appropriate clinical understanding of patient-controlled analgesia use? Now, let's look at the choices and determine which response aligns best with safe and effective nursing care. Option A. Clients are sometimes given a loading dose before being allowed to self-administer their prescribed dose through the patient-controlled analgesia device. Option B. Clients should be instructed to press the patient-controlled analgesia button only when their nurse is present. Option C. Patient-controlled analgesia use is contraindicated in patients who are receiving regional nerve blocks. Option D. Clients should be encouraged to allow family members to press the patient-controlled analgesia button if they are too sedated to do so. So which of these reflects best practice? The correct answer is Option A. Clients are sometimes given a loading dose before being allowed to self-administer their prescribed dose through the patient-controlled analgesia device. Let's break it down. A loading dose is often prescribed when patient-controlled analgesia therapy begins to quickly reach therapeutic pain relief levels, especially after surgery or in clients with cancer-related pain. Once that baseline comfort is achieved, the patient can self-administer smaller, safer boluses within preset limits. This promotes timely pain control and empowers the client with autonomy. Now, looking at the incorrect choices, Option B undermines the whole point of patient-controlled analgesia. It is designed so the client can manage pain as it starts, not wait until a nurse is nearby. Option C wrongly suggests patient-controlled analgesia cannot be used alongside regional nerve blocks, but in fact, combining these approaches is a common and effective multimodal strategy when carefully monitored. Option D is especially dangerous. Allowing family members to press the patient-controlled analgesia button known as patient-controlled analgesia by proxy, can result in overdose or oversedation and is strictly prohibited. Only the client should activate the device, and only when awake and in pain. So as a nurse, knowing the nuances of patient-controlled analgesia use is not just about managing a machine. It is about protecting your client, reinforcing safety, and making pain relief both effective and patient-centered. Now, let's challenge your ability to think like a nurse. How well can you apply pharmacology to a patient's background while making the safest choice? All right, it is time for the question. Number 3. A nurse is reviewing the medication reconciliation for a client recently prescribed naproxen for joint pain. Which of the following pre-existing conditions in the client's medical history would prompt the nurse to contact the primary healthcare provider before initiating therapy? Now, go ahead and take a good look at the options. Which one would make you pause and pick up the phone before starting this medication? Option A, rheumatoid arthritis. Option B, congestive heart failure. Option C, hypothyroidism. Option D, carpal tunnel syndrome. So which of these conditions should raise an immediate red flag? The correct answer is option B, congestive heart failure. Now, let's walk through why that is. And this part is key, so listen closely. Naproxen, like all nonsteroidal anti-inflammatory drugs, is known for causing sodium and water retention. And what does that mean for someone with congestive heart failure? Exactly. It worsens fluid overload, puts stress on the heart, and can lead to decompensation. Even worse, NSAIDs impair renal perfusion by blocking prostaglandins, which can make things spiral further. That's why, when you see heart failure and NSAIDs in the same sentence, it should immediately trigger concern. Now let's look at the other choices and break them down. Option A, rheumatoid arthritis. This is actually one of the primary conditions naproxen is used for. It provides symptom relief from joint inflammation and pain, and unless another comorbidity is present, it does not require a provider check-in. Moving on to option C, hypothyroidism. Here's the thing, hypothyroidism is an endocrine issue, but it does not interact directly with naproxen. There's no major concern unless other risks are present, so it is not the answer. Finally, option D, carpal tunnel syndrome. While naproxen might be prescribed for some relief in this case, it is completely safe to use as long as the client is otherwise stable. So, let this be your NCLEX takeaway. When you are reviewing medications like naproxen, always scan the history for cardiovascular conditions like heart failure. If it's there, pause, assess, and clarify before giving that first dose. That's the kind of clinical thinking the NCLEX wants to see. All right, time to pivot. We're diving into toxicology now, and trust me, this is one of those essential topics you need to have down cold for both the NCLEX and practice. Let's jump into the question now. Here comes your question number 4. A client is brought to the emergency department with suspected acetaminophen overdose after ingesting a large quantity of over-the-counter pain medication several hours ago. The nurse anticipates that the provider will prescribe which of the following medications as the most appropriate antidote to prevent hepatic injury. Now, take a moment and think about which of these options acts directly on the liver to prevent damage in this situation. Option A, acetylcysteine. Option B, naloxone. Option C, atropine sulfate. Option D, protamine sulfate. So which one of these should you expect the provider to order immediately? The correct answer is option A, acetylcysteine. Let's walk through why. And this is critical for both test-taking and real-world nursing. Acetylcysteine, also known as N-acetylcysteine or NAC, is the definitive antidote for acetaminophen overdose. Here's how it works. It helps the liver by restoring glutathione, a substance that neutralizes toxic metabolites of acetaminophen and prevents them from destroying liver cells. Time is everything. The earlier it is given, ideally within 8 to 10 hours of the overdose, the better the chances of avoiding liver failure. Now let's talk through why the other options do not apply. Option B, naloxone is often confused in overdose scenarios, but it is used for opioid toxicity, not acetaminophen. It reverses respiratory depression from drugs like morphine or heroin, but it offers zero protection for the liver. Option C, atropine sulfate is an anticholinergic that we use in bradycardia or organophosphate poisoning, again, completely unrelated to acetaminophen overdose. And option D, protamine sulfate is used to reverse the effects of heparin, especially if bleeding becomes a concern, but it has no therapeutic role in treating liver damage or acetaminophen toxicity. So here's your NCLEX pearl. If you see acetaminophen overdose in the question stem, your brain should immediately look for acetylcysteine, because protecting the liver early is the key to saving that patient's life. Let's pause for a second. Are you ready to take the NCLEX with confidence? If not, don't worry. The complete NCLEX review course has 100 animated hours, 500 recorded hours, 5,000 high-yield practice questions, 500 NGN case studies, and 15 mock exams built to mirror the real test. You also get a 1-year ebook. Enroll now and get 70% off. Limited time offer. The link is right in the description. Let's dive into a classic pediatric safety scenario that every nurse needs to be ready for. One that could easily show up on your exam or in real clinical practice. Ready or not, here's the next question. Question number 5. A pediatric nurse is reviewing medications recently administered to a child who presents with acute encephalopathy, profuse vomiting, altered level of consciousness, and elevated liver enzymes following a viral illness. The healthcare provider suspects Reye's syndrome. Which medication in the child's history most likely contributed to the development of this condition? Think carefully through the options and connect it to your knowledge of pharmacology and pediatric care. Option A, naproxen. Option B, aspirin. Option C, acetaminophen. Option D, loratadine. Now let us break down the correct response and understand the clinical reasoning behind it. The correct answer is option B, aspirin. Here is why this matters. Aspirin, also known as acetyl salicylic acid, is directly linked to Reye's syndrome when given to children recovering from viral infections such as influenza or chickenpox. This condition, although rare, is extremely serious. It causes rapid liver failure and swelling of the brain, and the mechanism is believed to involve damage to the mitochondria inside liver cells. Because of this, aspirin and other salicylate-containing products should be completely avoided in anyone under 18 years of age unless specifically prescribed by a provider for rare conditions. Now, let us go over the incorrect options and explain why they do not apply here. Option A, naproxen is a non-steroidal anti-inflammatory drug, but it is not associated with the development of Reye's syndrome. While caution is still advised when using it in children due to the risk of stomach and kidney side effects, it does not cause the same toxic reactions seen with aspirin. Option C, acetaminophen is actually the go-to pain reliever and fever reducer in children with viral illnesses. It must still be used carefully to avoid overdose, which can harm the liver in a different way, but it is not linked to Reye's syndrome. And option D, loratadine is an antihistamine used to manage allergies and has no impact on liver function or brain swelling. So the key NCLEX takeaway here is this. If you see a child with signs of brain and liver dysfunction following a viral illness, and aspirin is part of the medication history, that is a huge warning sign. Always remember, teaching families to avoid aspirin in children is not just a guideline. It is a life-saving intervention. This next one is all about medication safety, and it is something every nurse must be able to teach confidently to clients and families. Let the question speak for itself. Here comes your question number 6. During a pharmacology teaching session on medication safety, a nursing instructor emphasizes the importance of safe dosing when administering over-the-counter analgesics. Which of the following reflects the maximum recommended adult dosage of acetaminophen within a 24-hour period to avoid hepatotoxicity? Let us carefully examine each option and identify the safe upper limit for adults. Option A, 3,200 milligrams per day. Option B, 4,000 milligrams per day. Option C, 5,500 milligrams per day. Option D, 6,000 milligrams per day. So what is the correct maximum daily dose for adults to avoid liver injury? The correct answer is option B, 4,000 milligrams per day. Now, let us break this down together. The Safe Food and Drug Administration approved maximum dose of acetaminophen for healthy adults is 4,000 milligrams in a 24-hour period. Anything above that, especially when taken repeatedly over several days, can place the liver at serious risk. This is especially dangerous for individuals who consume alcohol, have malnutrition, or live with pre-existing liver disease. Even more concerning, many people are unaware that acetaminophen is found in numerous over-the-counter medications, including cold, flu, and sleep aids, making unintentional overdoses very common. Now, let us take a quick look at the other choices and why they are incorrect. Option A, 3,200 milligrams per day is sometimes recommended by certain manufacturers or for high-risk populations, but it is not the standard limit for the general adult population. Option C, 5,500 milligrams per day, far exceeds the therapeutic range and should be considered a potential overdose. Any dose above 4,000 milligrams in one day must be managed with clinical evaluation and possibly antidote therapy. Option D, 6,000 milligrams per day is extremely unsafe and carries a high risk for acute liver failure, particularly if taken all at once or in a short period of time. So the key NCLEX takeaway here is this. Always teach clients to read labels, track cumulative dosing, and know that the absolute upper limit of acetaminophen for adults is 4,000 milligrams per day. Anything beyond that puts the liver in danger, and nurses are the front line in preventing those errors before they happen. Let's take it up a notch. This question focuses on medication safety and tests your skill in catching the most harmful side effects pain drugs can cause. This one's going to test your judgment. Here it is, your question number 7. A nurse is teaching a pharmacology class about serious adverse effects associated with commonly used adjuvant analgesics. Which of the following medication pairings is accurately matched with its most life-threatening adverse effect? Now let us examine each option and determine which combination poses the most immediate and severe threat to the client. Option A, gabapentin, pancreatitis. Option B, celecoxib, hepatotoxicity. Option C, tramadol, seizures. Option D, aspirin, anaphylaxis. So which pairing correctly identifies the most dangerous potential reaction? The correct answer is Option D, aspirin, anaphylaxis. Let us break this down together. While aspirin is widely known for causing stomach upset, gastrointestinal bleeding, and even tinnitus at higher doses, one of its most life-threatening complications is anaphylaxis. This is a severe allergic reaction that can occur suddenly and unpredictably, especially in individuals with asthma, nasal polyps, or a known sensitivity to aspirin. Symptoms can include bronchospasm, swelling of the airway, low blood pressure, and potentially fatal respiratory failure. The response must be immediate. Stop the drug and administer epinephrine without delay. Now, let us talk through the incorrect pairings. Option A, gabapentin. Pancreatitis is not accurate because pancreatitis is not a recognized common or serious adverse effect of gabapentin. Gabapentin is typically used for nerve-related pain, and while it can cause drowsiness, dizziness, or peripheral swelling, pancreatitis is not part of its usual risk profile. Option B, celecoxib. Hepatotoxicity is also misleading. While rare liver effects have been reported, the most significant dangers of celecoxib involve cardiovascular risks like blood clots and heart attack, as well as gastrointestinal complications. Hepatotoxicity is not its primary concern. Option C, tramadol. Seizures might sound convincing. And yes, tramadol can lower the seizure threshold, especially in high doses or when used with certain other medications. But even then, seizures are not considered the most universally life-threatening adverse effect compared to anaphylaxis. The bigger clinical danger with tramadol often involves serotonin syndrome when combined with other serotonergic agents. So here is your NCLEX insight. When it comes to medication safety, do not just memorize side effects. Know which ones require immediate action to save a life. And when it comes to aspirin, always think anaphylaxis, especially in clients with allergy risks. Get ready to level up. This question dives into toxicology emergencies, where even the slightest symptom might reveal a life-threatening situation. And just like that, here's your question number 8. A nurse is caring for a client in the emergency department who has ingested a potentially lethal amount of aspirin. The client presents with altered mental status, hyperventilation, and nausea. Which assessment finding should the nurse recognize as most indicative of life-threatening aspirin toxicity and warranting immediate intervention? Take a moment to evaluate these options and ask yourself, which one of these symptoms demands urgent action? Option A, pulmonary edema. Option B, tinnitus. Option C, diaphoresis. Option D, low-grade fever. So which of these signals the greatest immediate risk to life? The correct answer is Option A, pulmonary edema. Let us talk through this like we are in the emergency department together. Pulmonary edema in the context of aspirin toxicity is a major red flag. And here is the key. It is not due to heart failure, but rather non-cardiogenic causes. Aspirin can directly damage the lungs and increase capillary permeability, leading to fluid buildup, crackles, pink frothy sputum, and oxygenation problems. When you hear those wet lung sounds and see hypoxia, think respiratory crisis, and act fast with oxygen therapy, potential ventilatory support, and immediate provider notification. Now, what about the other options? Option B, tinnitus is definitely a known sign of salicylate toxicity, and it is often one of the first clues that levels are rising. But it is not life-threatening on its own and does not require emergency intervention. Option C, diaphoresis or sweating, is the body's way of responding to metabolic stress and elevated temperature, but again, it is nonspecific and not dangerous by itself. Option D, low-grade fever can occur in aspirin overdose due to the uncoupling of oxidative phosphorylation, which affects temperature regulation, but it is also something you manage supportively and monitor. So here is your NCLEX pearl. In overdose scenarios, always assess which symptom shows the body is crashing. And in this case, pulmonary edema is that sign. When the lungs are failing, the clock is ticking. And your quick recognition can be the difference between recovery and respiratory failure. This next scenario is all about connecting medication safety with the client's medical history, a crucial skill for every nurse preparing for the NCLEX and practicing at the bedside. Let's see how you do on this one. Here comes the question number 9. A nurse is reviewing a new prescription for celecoxib in a client recently evaluated for chronic joint pain. Which of the following medical history findings should prompt the nurse to question the safety of administering this medication? Take a moment to review each option and ask yourself, which of these conditions raises the biggest red flag with celecoxib use? Option A, chronic tension headaches. Option B, ankylosing spondylitis. Option C, recent myocardial infarction. Option D, primary dysmenorrhea. So which one of these should make you pause before administering the medication? The correct answer is option C, recent myocardial infarction. Let us break this down together. Celecoxib is a selective cyclooxygenase 2 inhibitor, which means it helps reduce inflammation and pain with fewer gastrointestinal side effects compared to traditional non-steroidal anti-inflammatory drugs. However, here is the catch. It comes with a serious black box warning for cardiovascular risk. Celecoxib can increase the chance of heart attack or stroke, especially in clients with a history of cardiovascular disease. That is why it is contraindicated in clients who have recently had a myocardial infarction. If you see that in the client's chart, the safest action is to contact the healthcare provider, an advocate for a different pain management option. Now let us walk through the other options and understand why they do not pose the same level of concern. Option A, chronic tension headaches may not be the most common reason to prescribe celecoxib, but in the absence of heart issues, it can be used for off-label relief of muscle tension. Option B, ankylosing spondylitis is actually an approved indication for celecoxib. Since it is an inflammatory spine condition, celecoxib's anti-inflammatory action is very useful in managing the chronic pain and stiffness that come with it. Option D, primary dysmenorrhea, which refers to painful menstrual cramps, is another common reason celecoxib may be prescribed. Unless the client has cardiovascular risks, celecoxib is considered both safe and effective for this condition. So here is your NCLEX pearl. Before giving any non-steroidal anti-inflammatory drug, and especially selective cyclooxygenase 2 inhibitors like celecoxib, always scan the chart for recent or active cardiovascular history. If you see recent myocardial infarction, that is your cue to stop and speak up. Medication safety starts with your vigilance. Let us now focus on therapeutic management, because knowing which medications are appropriate for specific types of arthritis can be the difference between effective relief and inappropriate treatment. And we are live with the question. Here comes your question number 10. A nurse is developing a care plan for a client recently diagnosed with osteoarthritis who reports persistent joint stiffness and pain during movement. Which of the following medications should the nurse anticipate being prescribed to help manage this client's symptoms? As you review the options, remember to consider the nature of osteoarthritis. It is a degenerative, non-inflammatory joint condition. Option A, colchicine. Option B, adalimumab. Option C, oxyprozin. Option D, hydroxychloroquine. So which medication makes the most sense for managing this client's symptoms? The correct answer is option C, oxyprozin. Let us break it down. Oxyprozin is a non-steroidal anti-inflammatory drug commonly used for treating pain and stiffness related to osteoarthritis. Because osteoarthritis involves cartilage breakdown and mechanical stress on joints, medications that reduce inflammation and offer pain control are often needed. Oxyprozin stands out due to its long half-life, which means it is usually taken once a day, making it more convenient for clients managing chronic pain. However, like all non-steroidal anti-inflammatory drugs, it comes with risks, including kidney injury, stomach ulcers, and cardiovascular concerns, so monitoring is essential. Now let us go over the other options to understand why they are incorrect. Option A, colchicine is used to treat acute gout attacks by reducing inflammation caused by uric acid crystals, but it does not target the cartilage degeneration that defines osteoarthritis. Option B, adalimumab is a biologic agent used to treat autoimmune inflammatory conditions such as rheumatoid arthritis and psoriatic arthritis. It is not useful for the non-inflammatory joint breakdown seen in osteoarthritis. Option D, hydroxychloroquine is also used in autoimmune disorders like lupus and rheumatoid arthritis as a disease-modifying drug, but it offers no benefit in osteoarthritis management. So here's your NCLEX teaching point. Osteoarthritis is mechanical, not autoimmune, and medications like oxyprozin are prescribed to reduce pain and stiffness, not to suppress the immune system. As nurses, knowing which drugs fit the condition helps us anticipate provider orders and educate clients accurately. Right before we get into the question, let me ask you this. Is your NCLEX prep complete? If not, the complete NCLEX review course gives you 100 hours of animations, 500 hours of lecture content, 5,000 high-yield questions, 500 NGN case studies, and 15 mock exams, all with a year-long ebook. Save 70% today, but the deal won't last. Click the description link to enroll and start strong. This next question highlights a critical concept in safe opioid administration. Understanding how to respond quickly when a client experiences symptoms right after medication. Let's fire up your brain. This is the question. Number 11. A client who received intravenous fentanyl 50 micrograms 10 minutes ago becomes acutely dizzy and nearly collapses while being transferred from bed to chair. The nurse supports the client safely into the chair. Which action should the nurse take first? As you read through these options, think like a nurse at the bedside. What is the most immediate priority after a post-opioid near fall? Option A. Monitor the patient's vital signs. Option B. Place the client in a side-lying recovery position. Option C. Notify the rapid response team. Option D. Administer prescribed oxygen via nasal cannula. So which action comes first to guide your next steps? The correct answer is Option A. Monitor the patient's vital signs. Let us walk through this together. Fentanyl is a strong opioid with rapid onset, especially when given intravenously. One of its effects is vasodilation, which can lead to orthostatic hypotension. And that is likely what just happened here. The client got up too soon after a dose, resulting in sudden dizziness and near collapse. But before jumping into emergency responses, the very first thing you must do is assess. And that starts with checking the client's blood pressure, heart rate, and respiratory rate. This assessment will help you decide if this is a mild orthostatic drop or something more serious, like opioid-induced respiratory depression. Now, let us review the other choices. Option B, place the client in a side-lying recovery position is helpful if the client is unconscious or at risk for aspiration. But in this case, the client was upright and likely still alert, so this would not be the priority. Option C, notify the rapid response team might seem appropriate, but it is not the first step unless the client is showing signs of severe instability, like unresponsiveness or dangerous vital signs, and we do not know that yet. Option D, administer prescribed oxygen via nasal cannula could be helpful if the client was showing signs of hypoxia or respiratory distress, but there is no indication of that here. Giving oxygen without assessment could delay the correct intervention. So the NCLEX takeaway is this. When a client becomes symptomatic after opioid administration, your first move is not panic, it is assessment. Check those vital signs, stay calm, and use your findings to drive your next action. That is nursing judgment in real time. Let us shift our focus to patient-controlled analgesia, a powerful method for managing pain that requires vigilant monitoring to ensure client safety. Now, take a look at this one. Here comes your question number 12. A client is receiving intravenous hydromorphone via a patient-controlled analgesia device for post-operative pain management. Which assessment should the nurse prioritize to ensure the client's safety during opioid therapy? As you consider the options, think about what vital sign gives you the earliest and most critical clue that something could be going wrong. Option A, blood pressure. Option B, sedation scale rating. Option C, bowel movement frequency. Option D, self-reported pain relief score. So which one of these comes first when we are talking about safety monitoring? The correct answer is Option A, blood pressure. Let us break this down in real clinical terms. Hydromorphone is a highly potent opioid analgesic, and when it is administered through the intravenous route, it can cause peripheral vasodilation. This vasodilation leads to a drop in blood pressure, especially in postoperative clients who may be fluid depleted, or older adults with compromised circulatory status. Monitoring blood pressure helps the nurse catch this early and intervene before more serious complications like syncope, falls, or organ hypoperfusion occur. Now, let us walk through the other choices. Option B, sedation scale rating is certainly important, especially when monitoring for respiratory depression, which is a major concern during opioid therapy. However, changes in blood pressure often appear first, making it the higher priority for immediate safety. Option C, bowel movement frequency addresses the well-known issue of opioid-induced constipation, but this is not an urgent safety threat in the immediate postoperative period. It is monitored over time, not as a first priority. Option D. Self-reported pain relief score is important for evaluating the effectiveness of the therapy, but this is only assessed after confirming that the client is physiologically stable. So remember this key NCLEX insight. When managing opioid therapy, especially through patient-controlled analgesia, the first priority is monitoring for hemodynamic instability. And that starts with assessing blood pressure. Keeping a close eye on this vital sign allows nurses to protect the client before deeper complications arise. All right, let's talk about pediatric perioperative care, where your understanding of a child's development is just as important as your nursing skills. All right, bring your focus. Here comes the question. Number 13. A nurse is preparing a 3-year-old child for a scheduled incision and drainage procedure involving a large abscess on the left lower extremity. Based on the child's developmental stage and the invasiveness of the procedure, the nurse anticipates that which type of anesthesia will most likely be used. As you think through the options, consider what kind of sedation offers the safest and most effective experience for a preschool-aged child facing an invasive and potentially painful procedure. Option A. Conscious sedation with midazolam and local infiltration. Option B. General anesthesia via inhalation or intravenous agents. Option C. Epidural anesthesia with adjunct opioid. Option D. Local infiltration with lidocaine only. So which anesthesia approach is most appropriate for this age group and situation? The correct answer is option B, general anesthesia via inhalation or intravenous agents. Now let us unpack why this is the best choice. General anesthesia is the gold standard for preschool-aged children undergoing invasive surgical procedures. At 3 years old, a child cannot reliably remain still, tolerate discomfort, or understand procedural instructions. General anesthesia provides complete unconsciousness, pain control, and anxiety relief, which are essential for safely performing a surgical incision and drainage on a large abscess. It not only ensures the child's comfort but also protects the airway and allows the surgical team to operate without interruption. Now, let us look at the other options and explain why they are not suitable in this scenario. Option A, conscious sedation with midazolam and local infiltration, may work for older or highly cooperative children, but it is not safe for a 3-year-old who may become distressed or move during the procedure. This could compromise both safety and effectiveness. Option C, epidural anesthesia with adjunct opioid is sometimes used in pediatric surgery, especially for lower body procedures, but it is rarely used on its own without general anesthesia in children this young, because it does not provide unconsciousness or guaranteed immobility. Option D, local infiltration with lidocaine only might seem simple, but it would not be nearly enough to manage pain or distress in a young child undergoing an incision and drainage of a large abscess. In fact, the psychological trauma could be significant. So, here is your NCLEX clinical takeaway. When caring for toddlers and preschoolers, remember that developmental stage matters. For invasive procedures like surgical drainage, general anesthesia is the safest and most effective option. Let us turn now to pediatric pain management, a topic where safety, evidence-based practice, and developmental understanding all come together. This one's important. Listen closely to the question number 14. Following a pediatric pain management training, a nurse is reviewing key concepts for safely administering analgesics to children. Which of the following statements indicates accurate understanding of evidence-based pediatric pain management principles? Think carefully here. Which of these statements reflects current safety guidelines and pharmacologic best practices for pediatric clients? Option A, patient-controlled analgesia can be initiated in children as young as 7 years old. Zrenia. Option B, topical benzocaine sprays are the preferred option for infants undergoing minor procedures. Zrenia. Option C. Transdermal fentanyl patches are ideal for managing sudden, acute pain episodes in pediatric patients. So, which of these reflects the most accurate, up-to-date clinical guidance? The correct answer is option A, patient-controlled analgesia can be initiated in children as young as 7 years old. Let us break this down. This statement is true and supported by pediatric pain management guidelines. Children as young as 7 can safely use patient-controlled analgesia when they demonstrate the cognitive and physical ability to understand the device, follow instructions, and self-report pain. This method empowers young clients to manage their own pain effectively, especially in postoperative settings or during treatment for conditions like cancer. Now, let us explore the remaining options and explain why they are incorrect. Option B, topical benzocaine sprays are the preferred option for infants undergoing minor procedures. is not correct because benzocaine is contraindicated in infants under 2 years of age due to the risk of methemoglobinemia, a rare but life-threatening condition that reduces oxygen delivery in the blood. Instead, safer alternatives like sucrose solutions or topical anesthetic creams, such as lidocaine prilocaine, should be used. Option C, oral codeine is a reliable and safe option for post-operative pain control in children. Is outdated and dangerous. Codeine metabolism is highly variable in children, and those who are ultra-rapid metabolizers may convert it into morphine too quickly, leading to respiratory depression or even death. Because of this, it is no longer recommended in pediatric practice. And option D, transdermal fentanyl patches are ideal for managing sudden, acute pain episodes in pediatric patients, is also incorrect. Fentanyl patches are designed for long-term, chronic pain management in opioid-tolerant patients. They have a delayed onset and are never used for rapid pain control or for children who have not already built up opioid tolerance. So, your NCLEX pearl is this. When it comes to children in pain, safe medication use requires developmental awareness, evidence-based dosing, and avoiding high-risk drugs like codeine or inappropriate formulations like transdermal fentanyl for acute needs. When used properly, patient-controlled analgesia is a powerful and safe option, even for kids when they are ready for it. Time to work through a question that highlights whole-person care, where empathy and medical knowledge come together to support recovery on every level. Now, let's see what you've got. Check out the question number 15. A nurse is caring for a client who underwent an above-the-knee amputation 3 weeks ago and now reports persistent burning and cramping pain in the absent limb. After ruling out surgical site infection or neuroma, the healthcare provider confirms a diagnosis of phantom limb pain. Which medication does the nurse anticipate will be most appropriate for initial pharmacologic management? As you analyze the options, focus on which one aligns best with treating neuropathic pain at its source. Option A, haloperidol. Option B, amitriptyline. Option C, morphine sulfate. Option D, diphenhydramine. So, which medication should be expected in the initial treatment plan for this client? The correct answer is option B, amitriptyline. Now, let us explore why this choice makes clinical sense. Amitriptyline is a tricyclic antidepressant commonly used off-label for neuropathic pain, including phantom limb pain. It helps by increasing serotonin and norepinephrine levels in the central nervous system, which can reduce the perception of burning and cramping pain caused by nerve misfiring in the absence of a limb. This medication is frequently used as a first-line agent for phantom limb pain because of its effectiveness in managing centrally mediated symptoms. Let us now consider the incorrect options. Option A, haloperidol is an antipsychotic with no role in pain relief, particularly for neuropathic conditions. It may contribute to sedation but does nothing to address the actual source of the pain. Option C, morphine sulfate is a strong opioid, but opioids are no longer considered the first choice for phantom limb pain due to their limited efficacy for nerve pain and high risk of dependency. They may be used later if non-opioid agents fail, but they are not the starting point. Option D, diphenhydramine is an antihistamine, typically used for allergies or sleep disturbances with no impact on pain transmission in the nervous system. So, your NCLEX clinical takeaway is this. Phantom limb pain is real, it is rooted in nerve dysfunction, and medications like amitriptyline are key players in managing it effectively without jumping straight to opioids. Always validate your client's experience and use your pharmacologic knowledge to guide them toward relief that is both safe and effective. Before we break down this question, here's a game changer. The complete NCLEX Review online course gives you 100 hours of animation, 500 hours of recorded content, 5,000 essential questions, 500 NGN-style clinical case studies, and 15 full mock exams. Plus, you'll get a detailed NCLEX ebook with 1-year access. Get in now. 70% off, but not for long. The link's in the description. Thousands of future nurses are already ahead. Don't get left behind. Let us move into a question that tests your understanding of professional boundaries, because safe practice is not just about what we do, but knowing where our role ends. Keep your momentum. Here's the next big one. Question number 16. While auditing the nursing care plan for a client with long-standing chronic pain who receives scheduled doses of morphine sulfate, the nurse notes one intervention that exceeds the nurse's scope of practice and must be corrected before the plan can be implemented. Which entry requires immediate revision? Read each choice carefully and consider. Which action crosses the line from nursing responsibility into a provider's role? Option A. Modify the prescribed opioid dosage based on the client's current pain rating. Option B. Maintain continuous pulse oximetry while the client is on opioid therapy. Option C. administer the opioid dose if the respiratory rate is 14 breaths per minute. Option D, initiate a bowel regimen that includes a stool softener and increased fluids. So which of these should be flagged and removed from the plan? The correct answer is option A, modify the prescribed opioid dosage based on the client's current pain rating. Let us talk through this. While nurses are absolutely responsible for assessing pain and advocating for appropriate relief, they cannot independently alter medication dosages. That includes opioids like morphine sulfate. If the pain rating is high and the current dose is ineffective, the correct action is to document the assessment and notify the healthcare provider. Not to adjust the dose yourself. Changing the medication regimen without a provider's order goes beyond the nurse's legal scope and must be corrected immediately. Now let us examine the other options and why they are appropriate. Option B, maintain continuous pulse oximetry. While the client is on opioid therapy is an excellent safety measure, especially in clients who are elderly, opioid naive, or receiving high doses. It helps detect early signs of hypoxia before visible symptoms arise. Option C, administer the opioid dose if the respiratory rate is 14 breaths per minute is also acceptable. 14 breaths per minute falls within the normal adult respiratory range, and unless there are signs of sedation or instability, it is safe to proceed. Option D, initiate a bowel regimen that includes a stool softener and increased fluids is a standard and necessary nursing intervention for clients on chronic opioid therapy. It helps prevent opioid-induced constipation, which is one of the most predictable side effects of drugs like morphine. So here is your NCLEX takeaway. Nurses play a critical role in monitoring, documenting, and advocating. But we do not modify medication dosages. When in doubt, always go back to the provider, because protecting your license is just as important as protecting your client. Now we turn to a critical care setting, where success hinges on identifying early warning signs before a full-blown emergency unfolds. Challenge time. Here comes the question number 17. The nurse is monitoring a critically ill client on mechanical ventilation who is receiving a continuous infusion of fentanyl and midazolam for sedation and analgesia. Which of the following findings should the nurse recognize as a clinical indicator of fentanyl toxicity? As you evaluate the options, focus on what the body shows when central nervous system depression from opioids becomes dangerous. Option A, pinpoint pupils. Option B, restlessness and agitation. Option C, hyperactive bowel sounds. Option D, hypertension and flushed skin. So which one of these is the most classic sign of opioid toxicity? The correct answer is option A, pinpoint pupils. Now let us walk through why this is a critical finding. Fentanyl is a highly potent opioid that acts on the central nervous system, and one of its hallmark overdose signs is meiosis, or pupillary constriction. In a mechanically ventilated client, you may not see slowed breathing because the machine is assisting respiration. That is why pinpoint pupils, excessive sedation, and declining responsiveness become the most telling clues. These neurologic indicators are often the first visible signs of fentanyl toxicity, and they demand immediate attention. Now let us look at why the other options are incorrect. Option B, restlessness and agitation are typically seen when sedation is insufficient or during medication withdrawal. They are not signs of opioid overdose. Fentanyl toxicity leads to decreased activity, not increased. Option C, hyperactive bowel sounds would be inconsistent with opioid use, as opioids decrease gastrointestinal motility. Fentanyl toxicity often presents with constipation and reduced or absent bowel sounds. Option D, hypertension and flushed skin might suggest an allergic response or autonomic instability, but opioid toxicity is more likely to cause hypotension due to vasodilation. Flushing is not a reliable or specific indicator in this case. So here is your NCLEX takeaway. In critically ill clients on strong opioids like fentanyl, especially when combined with sedatives like midazolam, neurological assessments are key. Pinpoint pupils are a red flag for opioid toxicity, and nurses must act quickly to recognize and respond before deeper complications develop. Let us now move into a scenario that requires a deep understanding of advanced pain management, where providing consistent relief and addressing breakthrough episodes are both essential to compassionate care. Another opportunity to score. Let's see the question. Number 18. A client with advanced cancer reports persistent background pain along with unpredictable episodes of intense breakthrough pain. The nurse evaluates the current pain regimen and prepares to consult the primary healthcare provider for improved pain control. Which of the following prescriptions would be most appropriate to ensure both continuous and breakthrough pain relief? Think carefully. Which approach offers reliable around-the-clock comfort while also allowing rapid relief when pain suddenly intensifies? Option: A. Hydromorphone via patient-controlled analgesia. Option B. Oral celecoxib twice daily. Option C. Acetaminophen extended release every 8 hours. Option D. Oxycodone. Immediate release every 12 hours is needed. The most appropriate prescription is option A. Hydromorphone via patient-controlled analgesia. Let us break down why this is the best choice. Hydromorphone is a powerful opioid analgesic, and when delivered through a patient-controlled analgesia device, it provides both a steady baseline level of pain control and allows the client to self-administer additional medication during sudden breakthrough episodes. This method gives the client immediate access to relief, reduces delays, and is ideal for managing severe, chronic pain in cancer. It also allows for dose titration and personalized comfort. Now, let us consider the incorrect choices. Option B, oral celecoxib twice daily, is a non-steroidal anti-inflammatory drug used for mild to moderate inflammatory pain such as arthritis. It does not have the strength or flexibility needed to manage moderate to severe cancer pain and poses cardiovascular risks, especially with long-term use. Option C, acetaminophen. Extended release every 8 hours is a commonly used adjunct, but it is not powerful enough to manage significant pain on its own. It also has a maximum dosage limit due to liver toxicity risk, which makes it less useful for clients requiring round-the-clock pain relief. Option D, oxycodone immediate release every 12 hours is needed, is problematic because immediate-release opioids are typically dosed every 4 to 6 hours. Giving them only every 12 hours is not consistent with their pharmacologic profile and would likely lead to undertreated pain. So the key NCLEX point here is this. When managing advanced cancer pain, choose a strategy that covers both continuous pain and breakthrough episodes without delay. Hydromorphone via patient-controlled analgesia is the most effective and client-centered approach in this scenario. Shifting gears to pediatric discharge safety, a reminder that the care a child receives at home is just as essential as what happens inside the hospital walls. Think fast. This is the next question. Question number 19. A pediatric client is being discharged home following a tonsillectomy. The nurse is reviewing the prescribed medications intended for pain management during recovery. Which medication on the discharge list should prompt the nurse to immediately question its safety and contact the primary healthcare provider? As you go through the options, focus on which drug presents the most serious and well-known risk in this specific postoperative setting. Option A, codeine phosphate oral solution. Option B, acetaminophen oral suspension. Option C, tetracaine 0.5% topical lollipop. Option D, hydrocodone acetaminophen elixir. So, which medication should immediately raise a red flag? The correct answer is option A, codeine phosphate oral solution. Let us walk through why this is a major safety concern. Codeine is metabolized by the liver into morphine, and some children are ultra-rapid metabolizers. In these cases, even standard doses of codeine can lead to dangerously high levels of morphine in the bloodstream, resulting in severe respiratory depression or death. This risk is so serious that the United States Food and Drug Administration has issued a black box warning, and codeine is now contraindicated in all pediatric clients following tonsillectomy or adenoidectomy. If you see it ordered at discharge, it must be questioned and replaced with a safer alternative. Now, let us look at the other options. Option B, acetaminophen oral suspension is a safe and commonly prescribed pain reliever for children post-tonsillectomy. It is gentle on the stomach, does not interfere with platelets, and is effective for mild to moderate pain. Option C, tetracaine. 0.5% topical lollipop can be used under supervision to numb the throat locally and provide temporary relief. When used correctly and intermittently, it is considered a safe adjunct to systemic medications. Option D, hydrocodone acetaminophen elixir may be prescribed when pain cannot be managed by non-opioid agents alone. While it still requires careful monitoring for side effects, hydrocodone does not carry the same metabolic variability and toxicity risk as codeine. So here is your NCLEX insight. When reviewing pediatric discharge medications after a tonsillectomy, codeine should never be part of the plan. Recognizing that and advocating for safer options could be life-saving. Let us now turn our attention to one of the most commonly prescribed medications in cardiovascular care, aspirin, and recognize when its benefits may be overshadowed by its risks. Let's put your clinical brain to the test. Here's the question number 20. A nurse is monitoring a client who has been prescribed daily aspirin therapy for cardiovascular protection. During a routine assessment, which of the following findings should prompt the nurse to immediately suspect an adverse effect related to aspirin use? As you go through the options, think about which symptom points to the most well-known and serious complication of aspirin therapy. Option A, yellowing of the sclera. Option B, muscle cramping. Option C, black tarry stools. Option D, bradycardia. So which of these findings is the most urgent red flag for aspirin-related harm? The correct answer is option C, black tarry stools. Now let us walk through why this is such a critical finding. Black tarry stools, also known as melena, are a hallmark sign of upper gastrointestinal bleeding. Aspirin, especially when taken daily, can irritate the stomach lining and impair clotting by inhibiting platelet aggregation. This combination makes the client highly susceptible to developing ulcers and gastrointestinal hemorrhage. When melena is observed, it requires immediate evaluation and provider notification. Now, let us briefly look at the other options. Option A, yellowing of the sclera may suggest liver dysfunction or bile obstruction, but this is not a typical adverse effect of aspirin. While rare hepatic reactions can occur, they are not the most urgent or common concerns. Option B, muscle cramping is not associated with aspirin use. It may be linked to electrolyte imbalances, statins, or dehydration, but aspirin has no known effect on muscle function or mineral balance. Option D, bradycardia, or a slow heart rate, is also unrelated to aspirin. It may occur with medications like beta blockers or calcium channel blockers, but aspirin does not affect cardiac conduction or rate directly. So here is your NCLEX takeaway. Gastrointestinal bleeding is the most dangerous and prevalent risk associated with long-term aspirin use. If your client reports black, tarry stools, do not delay. Act immediately, because that sign could represent a life-threatening hemorrhage. Hold on just a second. Let's talk strategy. The complete NCLEX Review online course is your fast-track prep kit. 100 animated hours, 500 hours of lectures, 5,000 questions, 500 NGN-style case studies, and 15 exam simulations. All this plus a year-long NCLEX ebook. Act fast, it's now 70% off for a limited time. Visit our site using the link in the description and start today. Now we enter a high-pressure moment in the emergency room, where swift thinking and immediate action are the only things standing between survival and tragedy. Let's get into it. Here comes the question number 21. A client is brought to the emergency department after being found unresponsive with evidence of opioid use. The nurse notes pinpoint pupils, shallow respirations, and a respiratory rate of 6 breaths per minute. Which medication should the nurse anticipate administering to reverse the effects of morphine toxicity? As you consider each option, remember the classic signs of opioid overdose and what medication is specifically designed to counter them. Option A, atropine sulfate. Option B, flumazenil. Option C, activated charcoal. Option D, naloxone. So, which medication should the nurse be reaching for first in this emergency? The correct answer is option D, naloxone. Let us walk through the reasoning. Naloxone is a competitive opioid receptor antagonist, meaning it directly blocks the action of opioids like morphine, fentanyl, oxycodone, or heroin. It works rapidly to reverse respiratory depression, sedation, and hypotension, and can be administered through several routes: intravenous, intramuscular, subcutaneous, or intranasal. In this scenario, the client is displaying the classic triad of opioid toxicity: pinpoint pupils, central nervous system depression, and dangerously slow breathing. Naloxone must be administered immediately to restore adequate ventilation and prevent cardiac or respiratory arrest. Now let us review the incorrect choices. Option A, atropine sulfate is used to treat bradycardia or as an antidote for organophosphate poisoning. It does not bind to opioid receptors and would not reverse morphine toxicity. Option B, flumazenil is an antidote for benzodiazepine overdose, such as with midazolam or diazepam. It has no effect on opioid-related respiratory depression. Option C, activated charcoal is useful in some poisonings if given shortly after ingestion, but it is not appropriate in an unconscious client or when the symptoms have already progressed to severe central nervous system depression. It does not reverse opioid effects. So here is your NCLEX clinical takeaway. If your client is unresponsive, breathing shallowly, and showing pinpoint pupils, opioid overdose must be your first suspicion. And your immediate response should be naloxone, fast, focused, and followed by continuous monitoring for resedation or withdrawal. Let us now focus on medication monitoring, because catching subtle signs of adverse effects early can prevent serious complications. You've got this? Now let's take on the question number 22. A client with osteoarthritis is prescribed naproxen for joint pain management. During a follow-up assessment, which findings should the nurse recognize as a potential adverse effect requiring further evaluation? As you evaluate these choices, think about the most common and clinically significant risks associated with nonsteroidal anti-inflammatory drug use? Option A, occasional dizziness after standing. Option B, bleeding gums while brushing teeth. Option C, mild anxiety during the day. Option D, dry skin on the hands and arms. So which of these findings is a red flag that could indicate a complication from naproxen therapy? The correct answer is option B, bleeding gums while brushing teeth. Let us explore why this matters. Naproxen, like other non-steroidal anti-inflammatory drugs, inhibits cyclooxygenase enzymes, including cyclooxygenase 1, which plays a role in platelet function. By reducing platelet aggregation, naproxen increases the risk of bleeding. When a client reports unexpected bleeding, even something as seemingly minor as bleeding gums, it should raise concern for impaired clotting or gastrointestinal bleeding. These signs warrant further evaluation and possibly laboratory testing to assess for more serious issues. Now, let us walk through the other options. Option A, occasional dizziness after standing might suggest orthostatic hypotension, but this is not a common side effect of naproxen. It is more likely related to hydration, positional changes, or unrelated causes. Option C, mild anxiety during the day is not associated with naproxen use. Nonsteroidal anti-inflammatory drugs do not affect mood or central nervous system function in this way. Option D, dry skin on the hands and arms is a nonspecific symptom more likely related to environmental factors or dermatologic conditions. It is not connected to naproxen therapy. So here is your NCLEX clinical takeaway. When a client is on nonsteroidal anti-inflammatory drugs like naproxen, bleeding is your top safety concern. Bleeding gums, bruises, or black stools are not minor issues. They are warning signs that the medication may be compromising clotting ability, and they demand immediate follow-up. Let's conclude this series with a real-world scenario on safe medication administration. A reminder that even topical medications require careful handling to prevent serious complications. Cue the clinical thinking. Here it comes. Your question number 23. The nurse is applying a 5% lidocaine transdermal patch to a client's lower back to manage localized musculoskeletal pain. To prevent drug accumulation and potential toxicity, the nurse understands that the patch should be removed after how many hours. Focus on what timing is approved for this medication and what prevents systemic overdose. Option A, 24 hours. Option B, 72 hours. Option C, 16 hours. Option D, 12 hours. So which of these time frames reflects the safe and appropriate use of this topical anesthetic? The correct answer is option D, 12 hours. Let us walk through why this is so important. The 5% lidocaine patch is specifically designed for 12 hours on and 12 hours off. Leaving it in place longer than 12 hours increases the risk of lidocaine building up in the system, especially through prolonged skin absorption. And this can result in central nervous system effects, like confusion or seizures, or even cardiac rhythm disturbances. That is why this medication must be removed after 12 hours and the area kept patch-free for the next 12. Now, let us look at the incorrect responses. Option A, 24 hours is too long. While some patches like those used for nicotine or hormone therapy are made for full-day use, lidocaine patches are not. They are designed to allow skin recovery and to reduce the risk of toxic buildup. Option B, 72 hours is the wear time for a fentanyl patch. This timing is completely inappropriate for lidocaine and could cause dangerous levels to accumulate. Option C, 16 hours may sound reasonable, but it still exceeds the United States Food and Drug Administration approved duration. Even a few extra hours could increase systemic absorption beyond safe levels. So your NCLEX takeaway is this. With transdermal lidocaine, 12 hours on and 12 hours off is the gold standard. Anything more risks harm, and it is the nurse's job to monitor, educate, and document that timing with precision. That brings us to the end of this power-packed session on the pharmacology of analgesics. We've just walked through 23 high-yield NCLEX questions designed to sharpen your clinical thinking and boost your confidence. If you found this helpful, make sure you stay with us, because we're just getting started. We drop new NCLEX-focused videos every single day,